Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing health care to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, Safe Same-Day Discharge After Total Joint Replacement, straight from the experts. Presented by Dr. John Dearborn, orthopedic surgeon with the Washington Hospital Institute for Joint Restoration and Research. Dr. Dearborn is an orthopedic surgeon and innovative joint replacement specialist who has been perfecting his art for over 30 years. He is a West Coast pioneer for joint replacement specialty centers, founding the Center for Joint Replacement at Washington Hospital in 1999, now known as the Institute for Joint Restoration and Research, a comprehensive, multifaceted program that serves patients from all over the world. His blending of integrated systems with a compassionate, one patient at a time approach to caring for the arthritis patient has since been emulated widely by hospitals and healthcare systems throughout California and beyond. Over the past 5 years, Dr. Dearborn's rapid recovery protocols, combined with less invasive surgical techniques, have made same-day discharge following hip and knee replacement commonplace in the Bay Area. The IJRR program at Washington Hospital has won accolades throughout the West Coast. Please welcome Dr. John Dearborn.
Thanks, and good afternoon, and welcome to those people that are watching online. Thank you for that very generous introduction. As with any presentation, I like to put the goals out first to make sure we achieve those. And hopefully you're going to get the impression that safety is our primary concern. We'll get you some background behind same-day discharge. We'll certainly define what we mean by safe. We will discuss the ingredients. We'll spend most of the time on this, the ingredients required to create a safe experience from start to finish. And hopefully we'll be answering the question, am I a candidate for same-day discharge? And you should get some insight into expected outcomes. So let's dive in. You've already heard a little bit about me. I just finished my 26th year in practice, and we're very proud of our Center for Joint Replacement here at Washington Hospital, which is now called the Institute for Joint Restoration, renamed in 2012 when they built our new building. And I grew our program from doing about 90 joint replacements per year in 1997 to nearly 1,900 joint replacements in the year 2022. And our program has been widely emulated for efficiency. So if you look all around the Bay Area, all of those joint replacement programs that you'll see advertised basically copied us. And so we're proud of that here. Certainly our model works, which is why it's worth emulating. 11 years in a row we've won the Healthgrades Joint Replacement Excellence Award, which is given to the top 5% of programs in the nation, and some other accolades as well listed here. We have a regional draw in our program. Here's the pie graph with that light green small piece of the pie being Alameda County. Normally that would be the normal drawing area of this hospital, but you can see that the largest piece of the pie on the right is actually the peninsula. We are going to be talking about some different procedures here. We won't get into them in detail, but just at the outset, in case you don't know what a hip replacement is, when we replace a hip, we're removing the femoral head, which you see in that number 1 box, and we're relining the socket using a metal shell and a polyethylene bearing in the number 2 box, and putting an implant down inside the femur in the number 3 box, and we're all done at the end of number 4. And hopefully that's about 45 minutes. Knee replacement, we're resurfacing the ends of the bone, both the femur and the tibia. When we do a partial knee replacement, we're talking about resurfacing only one of the 3 compartments in the knee. These cartoons show a medial unicompartmental replacement, which we do a lot of and we'll be talking about a little bit today. And then another type of partial knee replacement, which is very popular, preferred by patients who have isolated wear in the patellofemoral joint. In fact, before coming over here today, I did 2 of these on the same patient. Why are we talking about same-day discharge? And the reason is because same-day discharge is a natural evolution of the decreasing length of stay trend that is happening with joint replacement. Patients are doing better faster, which is a good thing. We'll talk about why. In case you haven't noticed, hospitals aren't the most pleasant places to hang out for day after day. And cost containment is a special issue. And Kaiser has really taken the lead on this. For several years, Kaiser has been pushing most of their patients having joint replacement out the same day. So what we're doing really is behind what Kaiser has been doing for years. Here's a graph showing my hip replacement length of stay here at Washington Hospital starting in 1997, when I started practice. Our length of stay was about 3 days, maybe just over 4. Our lead physical therapist just came in the back of the room, and she can maybe tell me exactly how many days people stayed when she first got here. That was about the same time I did. But it was around 3 or 4 days, and the length of stay you see has gradually gone down. The length of stay is in the light blue, and you can see for 2020 it's less than 1 day because many patients go home the same day. And the blue bar is actually our complication rate, which is in percent. So as you can see, as length of stay has gone down, in fact, complication rates have also gone down. So this is not an issue of patients being kicked out of the hospital earlier and then having complications at home. Following the shortening of the length of stay, obviously we have more patients going home the same day, and here's our hip replacement, my hip replacement same-day discharge progression. You can see in 2018 is when we really started sending people out the same day. The light blue is our data. The darker blue is national data. So you see we're ahead of the national curve for same-day discharge. And fortunately, our complication rate here is we've been sending people out the same day is either flat or declining, so, which is very important. Same-day discharge, of course, is a hot topic now. We've been doing it for several years, but if you do a literature search like I did in preparation for this talk on PubMed, which I would encourage you to visit, it's a great site if you want to see research papers. It'll help you go to sleep at night too, reading some of these. But I did a search for same-day discharge joint replacement, looking for papers published just this year. And you can see there's 34 results, including this paper, which I'm going to highlight, which is entitled Same-Day Discharge Total Knee Arthroplasty in Octogenarians. So it's a hot topic, and in fact, I get in my inbox and my email advertisements for seminars on how to create a outpatient rapid recovery program. This is an advertisement from our American Academy of Orthopedic Surgeons, and that seminar is coming up later this month. Fortunately, we already have our own program, the most recent iteration being the Peninsula Surgery Center in Red Ridge Shores, which was founded in 2018. Construction finally completed in 2021 and then opened in May of 2022. This building and the program within it was designed specifically for joint replacement all the way through, mirroring the program that we've spent so much time developing and are so proud of here at Washington Hospital. And there are some pictures of Peninsula Surgery Center, which sits right on the lagoon in Red Ridge Shores. Beautiful spot. But as I mentioned, our same-day discharge program actually began in 2018, and I would say it was fueled by the pandemic as well. So you see there in 2020, we were up to a 50% same. This is a graph showing same-day discharge for total hips. These are my patients. I was already at a 50% same-day discharge rate in 2020, and it's just gone up from there. In 2022, we were doing half of those cases at Peninsula Surgery Center, and this year we're doing about 60% of our hip replacements at Peninsula Surgery Center, and we're at an 80% same-day discharge rate for total hips. So today in our program, there's 2 options for same-day discharge. The surgery can be performed in a hospital setting with discharge the same day. The Joint Commission on Hospital Accreditations and Medicare would call this a hospital outpatient department discharge. And then the second choice is having the surgery performed at an ambulatory surgery center, such as PSC, Peninsula Surgery Center, or Washington Outpatient Surgery Center. Which option's better? Well, with many questions, the answer is it depends. ASCs tend to be smaller. They're more of a relaxed environment. There's a lot less administrative hassle. You don't have to walk through admitting to get in there and deal with some of the red tape that you would in a hospital. But an overnight stay is often not possible. A hospital setting allows for the option to stay overnight if needed, which can be quite helpful. But, and we'll get into this a little bit later, hospitals tend to be a little less efficient. There might be some exposure to sick patients, although less so in our program where we have a quarantined building. And the cost is going to be higher in this setting. There are several published advantages of ASCs over hospitals for the same procedures being done. Obviously, hospitals treat many kinds of patients, including some with infections. ASCs screen out patients with contagious diseases, so those patients are never going to have surgery in an ASC and you won't be exposed to them if you choose to have surgery there as well. The CDC estimated in 2010 that the infection rate in an ASC was 50% less for the same procedure performed in a hospital. So there's some significant data. That's old data from 2010, but I don't think it's much different now. Second, there's a reduced risk of complications, other complications besides infection if you have your surgery in an ASC. ASC patients are less likely to visit an ER or to have a hospital admission compared with patients discharged the same day after surgery from a hospital. And those numbers are 0.07% for an ASC versus 0.52% for a hospital in the first 7 days. And those numbers go up if you extend out to 30 days. There's improved efficiency, obviously, in the ASC environment. The smaller staff size allows a better accountability and procedure specialization. The staff can be more aligned with the ASC mission. We don't have unions in our ASCs, so there's less interference there. As a result, patients spend about 20% less time in an ASC versus a hospital for the same procedure. That's not just our data, that's national data as well. There's also better control over scheduling in an ASC, so you're never going to have your surgery canceled because an emergency came in. ASCs operate at a lower cost. Obviously, there's a lot less overhead associated with these smaller programs, and as a result, ASCs can be 45 to 60% less expensive than hospitals. In fact, the Department of Health and Human Services estimated $15 billion in savings to taxpayers and $3 billion to Medicare if all of those patients who were eligible to have their procedure done in an ASC actually had it performed there. And so this is especially important considering that Medicare is upside down financially and we need to be finding less expensive ways to deliver care rather than more expensive ways. Patient copays are usually lower when care is received in an ASC as well, which obviously drives employers to encourage their patients to have those procedures at ASCs. At an ASC, you're going to have a little bit fresher and more focused staff, potentially. The one thing that we run into occasionally here is that I show up in the operating room on my inpatient day, and I may have staff who were here all night, and now they're going to be working with me in the operating room, which, and our staff is phenomenal. They can function very well even when they're exhausted, but you won't have that issue if you're having surgery at an ASC. And the improved working conditions, the staff not having to be there overnight or on weekends, can lead to better staff retention, less turnover, and better expertise for the staff, which obviously benefits surgeons when we have more expert staff, and it certainly benefits the patients. The final advantage I'll list for an ASC is the obvious, that for patients going home the same day, they're going to have more comfortable recovery at home. Obviously, this would be true if you had surgery in the hospital as well. But outpatient surgery centers tend to be less stressful. Your bed at home certainly is going to be more comfortable than a hospital bed. Your food will taste better. You're always going to get a better night's sleep at home, and your immune system is more accustomed to your home environment. So if you can go home the same day, I'd encourage you to do that. So let's get back into safe same-day discharge, which was the title of this presentation. And we'll start by defining what we mean by safe, which I think is important. It's more than just no complications. A safe patient going home means that their pain is under control. The patient's not dealing with some of the nuisances that can occur after surgery, like urinary retention, nausea from pain medications. The patient's mobile. These aren't patients that are being wheeled out in wheelchairs and are unable to walk. The patients are mobile, which means that their risk of falling is going to be less, which is super important. We worry about patients falling after surgery. And any existing medical problems that they had coming in are under control. And finally, and maybe even most importantly, that they have a solid backup plan in place at home. They've got a helper. They're not going home to an empty house. All part of safety. We can contrast this with an unsafe patient whose pain is poorly controlled, requiring a lot more pain medications, which might mean side effects like dizziness and nausea. The patient who's unable to safely get on and off a bed or to walk to the bathroom. Obviously, we've talked about the fall risk associated with an unstable patient. Patients who have underlying lung issues or heart issues, if they leave an ASC, or a hospital same-day discharge environment with those things unstable, they're going to end up in the emergency room, and that might not even be our emergency room, and we can't control necessarily how they're treated there. And lastly, if they're home alone and they don't have the lifelines, that's an unsafe situation. So we want that help at home. All right, so we're going to get into the ingredients that create that safe environment, and I just want to emphasize that this is a group effort. It's not just the surgeon, although we got the surgeon here in the upper left. What happens with lab testing ahead of time can help determine whether a patient's safe to have surgery, what anesthesia is doing, what the operating room staff is doing, the recovery room and how they manage the patient, super important, on-site physical therapy and what happens at home with physical therapy and with that caregiver, that help at home. All of those hands are touching the patient and influencing the safety of that same-day discharge. So we're going to walk through these ingredients, and these are broad categories. First, we're going to talk about patient selection. Very important ingredient to a safe same-day discharge. If you don't pick your patients right, you're going to have a lot more unsafe patients. We're going to talk about pre-surgery details of some little nuances, anesthesia methods, surgical techniques, and some post-surgery details which influence how safe the discharge is going to be. And obviously our goal is to have everybody going home safe. So we'll start with patient selection. That's a very broad topic. Where are we going to start with that? And what a lot of programs will do is they'll look to the literature for patients who were in a hospital environment and the goal was to go home the same day, but they failed. They weren't able to go home the same day. Fortunately, they were in a hospital, so they were able to stay overnight or so, but there have been lots of papers written about what the reasons are for people failing, and patient selection is an important piece of that. In this particular article in the Journal of Arthroplasty published this year, they outlined essentially, it obviously makes sense, an unhealthy patient should probably be done in the hospital. And unhealthy, according to this paper, were patients with poor nutrition especially, which might mean a high body mass index, especially a low serum albumin, patients who have baseline breathing difficulties, patients who have bleeding disorders, patients who are chronically using steroids. These are ones that had a statistically significant higher rate of falling out when the goal was to go home the same day. So we can start with those sort of medical issues and use those to screen out patients who might be considering same-day discharge. So for today, we're going to consider age. We're going to consider maybe a better measure, which is the American Society of Anesthesiologists classification, or ASA classification, which I'll use as a proxy for medical issues being stable. And then we'll talk a little bit about help at home. So patient selection. This is another paper that was published also earlier this year, which looked at some specific patient characteristics, and you can see age here, which I've circled, did not have a statistically significant impact on failure of same-day discharge. So age alone is not a criteria. When I think of age, I think of chronologic, which is the way we normally think of age, versus physiologic. I have some 60-year-olds who are unhealthy, and they're worse off than some of my patients who are pushing 90. So age alone is not a proxy for risk. It's the number and severity of specific medical issues is a more important measure. Here's a paper that I highlighted earlier, same-day discharge for total knee replacement in patients over the age of 80. And the conclusion of this article was that octogenarians undergoing outpatient total knee replacement had comparable complication rates to similar patients undergoing inpatient total knee. So they concluded that it can certainly be performed safely in people and over the age of 80, and that doesn't need to be a contraindication. So again, underscoring that age alone is not a criteria. Looking at what we've done at Peninsula Surgery Center since opening May of 2022, here's our age breakdown. You can see we've got some octogenarians out there on the far right, and those are numbers of patients there. So we've operated on more than 20 knee replacement patients who are over the age of 80. As I hinted at earlier, I think a better patient selection method is using the anesthesia classification. That classification is 1 through 6. I won't bother you with number 6, which is a brain dead patient. But ASA 1 is your normal, healthy patient. ASA 2 is a patient who has a mild systemic disease, one disease that is well controlled. ASA 3 has a more severe systemic disease that's not currently life-threatening. ASA 4 starts to get a sicker patient, et cetera, and 5 is even worse. So this is the ASA classification. How have things worked at PSC? And I think I have a graph of this. So we use patients who have an ASA class of 1 or 2 and select some patients with an ASA 3 who are medically stable. We have them check in with their primary care doctor or their specialist before we schedule them for surgery. And here's the breakdown of the ASA classes that we've done at PSC so far. So you see there's a handful of ASA 3s in there, especially on the knee side, but the bread and butter are ASA 1 and 2. So if you come into the office and you're in ASA 3 plus, ASA 4, and you need a new joint replacement, we're gonna schedule you at the hospital. So lastly, we'll talk about help at home. Help at home is so important. That person that's helping may be serving as your coach. They may be providing accountability. They hopefully are an encourager, which is super important. They may help manage medications, and they'll have the clear head. They're not taking the pain medication, so they can maybe keep track of it a little bit better than you might. And that person serves also as a gopher, and you might need things from the pharmacy. You might need meal help. You might need to be driven to the office the first time. Check-ins by neighbors, super helpful. And general trouble mitigation, super important for that eyes and ears at home. Okay, so the second ingredient, we'll talk about surgical technique. And what we've learned over the last 26 years is that less invasive is better. The whole minimally invasive term is sort of overstated, but certainly if we can do surgery less invasively, it seems to make a difference. On the hip replacement side, specifically what makes a difference, and this is based on our literature and the literature published, we know that reducing the dissection in our program cut our average length of stay to just over 1 day from 3 days when we initiated that in 2001. So we went from a 3-day length of stay to about 1 day, 1 to 2 days with just reduced dissection. So we know that that makes a difference. Shorter surgical time clearly makes a difference in every study, and reducing blood loss makes a difference in terms of how patients do after surgery. There are some things that do not make a difference, and the published literature bears this out. The first is surgical approach. We're doing primarily mini posterior surgery approaches at our ASC, and our patients are getting up and getting moving without any problem. In fact, if you look at the discharge home same-day discharge rate from 2022 in our program, the mini posterior same-day discharge rate was 60% last year, and for anterior approach was only 45%. And the literature is quite clear that it doesn't make a difference which approach you're using between these two if you're talking about going home the same day or having satisfactory early rehabilitation. The use of robots and computer guidance have also not proven to make a difference in your early recovery or even your outcomes at 1 year. In terms of knee replacement techniques, there are some things that make a difference. In 2004, we stopped everting the patella, which meant that our dissection that we carried out into the quad tendon didn't extend nearly as far up, and that shortened our length of stay substantially. Our patients had better flexion at 2 weeks and reduced use of an assistive device at the 2-week mark as well with that change in 2004. Shorter tourniquet times and reduced tourniquet pressures have been shown in the published literature to allow patients to rehab more quickly, to get up and walk, to get moving, to have a return in their quad function. Thigh pain is also mitigated by lower pressure and shorter times. There are some things that don't make a difference, robotic surgery being one of those. It doesn't improve the accuracy of an expert surgeon. It does increase the surgery time here at Washington Hospital by about 20 minutes, according to the rep who runs the robot here at the hospital. So add 20 minutes without improved accuracy. Custom cutting guides and custom implants have also not been shown to make a difference. There's a lot of published literature looking at patient outcomes early and out to 1 year, showing no difference with these technologies. A wise king once said that what has been will be again. What has been done will be done again. There is nothing new under the sun. Obviously, we talked about some novel medications and surgical approaches which are beneficial, but I remind people of this quote because there are things that come around again and again, repackaged as something new when they're not actually new. And part of that is because new technology is driven by industry. Industry wants to make money from the new technology. Unfortunately, they use physicians to market a lot of this new technology, and they pay those doctors to do so. So if someone's being paid to say a product is good, be skeptical, even if that's me, and wait for peer-reviewed data. Check for industry conflicts via the Sunshine Act, which is a government act that increases transparency for physicians who may be getting paid by industry to market their products. So the third ingredient I want to highlight is the anesthesia method. This is a super important area. This is that paper by Shen again, looking at those different characteristics that were associated with failure for same-day discharge. And on this you see general anesthesia is listed as statistically significant in terms of affecting the ability for patients to go home the same day. So we want to avoid general anesthesia, and we'll get into that a little bit more. You can see another one on the list is postoperative pain scores. All those post-op pain scores were highly statistically significant in terms of affecting same-day discharge. And that again falls into the realm of our anesthesiologists. But fortunately, they are prepared with regional anesthesia, which is our anesthesia method of choice. For knee replacements, the anesthesiologist performs what's called an adductor canal block. The adductor canal block is done in the upper thigh and numbs the sensory portion of the femoral nerve after it's given off its motor fibers to your quadricep muscle. And all of that complicated language just means that you get numbness on the front of your knee for about 8 hours, and hopefully you don't have any weakness. The spinal anesthetic is what covers you during the actual surgical procedure, typically lasts about an hour and a half, and is super helpful for reducing the overall pain that you experience after the procedure. That spinal is currently we use mepivacaine, but there's been several different agents that have been evaluated in the literature. It looks like mepivacaine is the winner currently. We have the anesthesiologist avoid giving narcotic pain medications, which do slow recovery. And they may use some sedation with a medication called propofol, Michael Jackson's sleep aid of choice. But they will monitor you while you're under propofol. About 1 in 5 patients will choose to stay awake and watch their operation. For hip replacements, again, a spinal is the best choice, and you can have some sedation if you don't want to be awake and listen to the noise. Okay, moving on to the perioperative details, which is going to be a little bit of a mishmash. The first thing to remember is that preemptive pain medication antiemetics means it's going to be preventative. So remember that prophylaxis means prevention, and so for pain we give prophylactic oral Celebrex in the holding area before going in the operating room. Celebrex is an anti-inflammatory that doesn't thin the blood, so it doesn't cause bleeding in the operating room. And we'll give an oral agent like tramadol. so that when you come out of your spinal anesthetic, you're not in as much pain as you would be if we didn't give that. We also give prophylactic anti-nausea medicine, expecting that nausea could be an issue. 3 different intravenous medicines are given. We also worry about urinary retention, especially in our male patients, but surprisingly, sometimes our women have that issue as well, and we give Flomax routinely to our men if they still have a prostate. We also do other things to help manage the bladder, because as you might have noticed, urinary retention is one of our things that we're always chasing. We have our patients void before surgery, before going into the operating room, and then we check with a bladder scanner the males to see what their post-void residual is, to see if they're able to empty their bladder all the way. And if they're not emptying, then we know after surgery that we're going to be chasing an over-distended bladder potentially. Which brings us to the next point, that we limit our intraoperative fluids so that we don't get an over-distended bladder while the spinal's working. When you're under a spinal anesthetic, you won't be able to control your bladder, and so we don't want to fill it up excessively with fluid while you're not able to empty. And we don't use urinary catheters, which we found helps actually our male patients be able to avoid better. Something about instrumenting the urethra with a catheter can affect the ability to void afterward. Some other considerations perioperatively. In the operating room, we give a medication called tranexamic acid, which helps stabilize clots that form on blood vessels in the operating room. Without this medication, sometimes after surgery, blood vessels that weren't bleeding during surgery will start to bleed after, and that can be a problem. But tranexamic acid has changed the game surgically in the operating room in terms of reducing our post-operative bleeding. So very important to give that. We also give medications in the knee joint and in the hip joint to reduce post-operative pain. We inject the capsule, which is the connective tissue right around the joint, with a variety of different medication cocktails. And we also use topical agents like one called ZynRelief, which we use in the knees, and you can look that up. It has a local anesthetic and anti-inflammatory property to it, and all the knees get it. The 5th ingredient is post-surgery details, and this is, again, super important. Our nursing staff is phenomenal, both at PSC and in our recovery room here at Washington Hospital. The recovery room, it's taken a bit of a culture change to get our nurses to use more oral pain medications when patients hit the PACU rather than going straight to intravenous medications. But the oral medications are slower in onset, they last longer, they produce less nausea, as long as, of course, you have a awake enough patient to be able to take something by mouth. Limiting the IV fentanyl and the IV Dilaudid has made the life easier for our physical therapists who get up our patients after. If a patient's received a lot of intravenous medications in the recovery room, they're not going to rehab nearly as well early after that surgery. And we also need to be considering that these medications affect urinary retention as well. So again, we're watching our patients post-operatively after they void and making sure that they're emptying their bladder. At PSC, we also have our charge nurse in the pre and post area making follow-up phone calls the next day, which is super helpful for identifying early problems at home. It's a nice confidence builder for patients as well. They know we care about them when we're calling them even after they're home. It's also important to have physical therapy after the surgery, and I don't think I believed that this was going to be so true at our outpatient surgery center, but I am so grateful that we have an experienced physical therapist on site. Our physical therapist works with my patients here in the hospital as well, and it has given our patients and our nursing staff great confidence that somebody who's been doing this for years is going to get that patient up on the day of surgery, usually 2 or 3 hours afterwards, make sure they're safe, and that they'll get tucked in at home with a visiting physical therapist who will come to their house through the home health care agencies that we use. And these are, again, I can't overemphasize the importance of having these people who function as our eyes and ears in the house. So that physical therapist coming out to the house can identify throw rugs that look like they're dangerous. They can work with the patients on their own stairs. They can evaluate patients who might be dehydrated and having low blood pressure. They can help patients adjust their pain medication. Super important to have that skilled person coming into the house. They can often identify minor problems that, if they're not addressed, will become major problems. So we're indebted to our home care agencies. That ends the material that I had to present today regarding safe same-day discharge, and I think we have some question and answer time available.
Yes, we do. Thank you very much, Dr. Dearborn. We have some questions first from our Facebook audience, and then we can take questions from our in-house audience. So the first question we have is, how long is an average hip and or knee replacement surgery?
Replacement take about 45 minutes, so they're very similar, skin to skin, from when we start the surgery until we end it. Of course, there's preemptive things that happen, and we've talked about that during this presentation. The anesthesiologist doing their nerve blocks, patients getting positioned in the operating room. Once a patient goes into an operating room, it may be an hour and 15 before they roll out, considering all the things that have to happen. But the surgery itself is about 45 minutes.
Okay, thank you. Our next question is, besides patient choice, is there anything else that factors into the decision to have surgery at an ASC versus a hospital?
For our patient population, they pick what they want to do. And I would say that as we've been in a pandemic and coming back out of a pandemic, maybe going back in again, patients tend to be more wary about being in the hospital than they used to be. So we sound it out to them. They'll ask questions here in the office, but ultimately the patient decides.
What are the do's and don'ts of a total knee replacement?
Are we talking about afterwards for the patient? Must be, because they're not going to ask me what my do's and don'ts are surgically.
I think it was do's and don'ts of total knee or hip replacement, yes.
Yeah, so after a knee replacement, the one don't is we're going to ask our patients to avoid high impact exercise, high impact sports, cutting and pivoting sort of things for the knees, especially because they don't have an anterior cruciate ligament after a knee replacement. If they've had a partial knee replacement, they do still have their stabilizing ligaments in the middle, but if patients get into these singles tennis and things like that, they're probably going to cause their joint replacements to loosen a little bit earlier. On the hip replacement side, I do have a lot of tennis players, but again, we ask them to avoid running and high impact things where there's a lot of pounding, because we think that that's probably going to shorten the life of the replacement.
Okay, the next question we have is, I'm considered a senior citizen who lives alone with no support at home. What are my options?
So if you don't have support at home and you're needed to have a joint replacement done, you do have options. And I try to get people home with help. That's certainly our bias. Rehab facilities certainly have their place, but our patients that we found that our patients who go to rehab facilities tend to do worse than those that go home with help. So I feel confident having patients in their environment with a physical therapist coming in and help is best. If a patient doesn't have any friends or family, which is obviously a sad situation, you can hire caregivers, and in our hip and knee binders we have caregiver organizations listed in the back, and so you can check those out. Of course, insurance doesn't pay for that service, so there's a cost associated with it. If those options are not possible, then patients can be discharged from a hospital setting to a rehab facility, a skilled nursing facility, for a stay of a week or two. And we sometimes do that, but it's about, I would say it's less than 1% of our patients that end up with that option.
Okay, thank you. And our last question, what should I do to prepare for a joint replacement surgery?
Oh, that's a great question. We could write a book on that. I'm sure a book has been written, in fact. Yeah, there is certainly information in our binder, but if I have a patient who's not exercising at all, the first thing I do is tell them to get on a stationary bike if they can access one, to start using their muscles, to start developing a little bit of muscle tone, Obviously, patients who are not eating well, who don't have a well-balanced diet, that's another important factor. And if patients are carrying a lot of extra weight, we might direct them to a ketogenic type diet program or some physician-supervised program. So maximizing your health and your fitness level as your arthritic joint will allow, that's the best way to prepare for this.
This concludes our program. Thank you, Dr. Dearborn, for this insightful presentation. And thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.